Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 219 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, O.J.S, a 53-year-old man presents with a 24-hour history of painful, swollen, red leg. On examination, O.J.'s temperature is 38.1 degrees Celsius, his blood pressure is 142 systolic 74 diastolic and his pulse rate is 84 beats per minute. O.J.'s right leg has changes consistent with cellulitis of the right calf and ascending lymphangitis. Investigations are done. The results are as follows. Total white cell count 14.3 times 10 power 9 per liter. The normal range is 4.0 to 11.0 times 10 power 9 per liter. C-reactive protein is 224 mg per liter. The normal range should be below 10. C-reactive protein enhances phagocytosis by binding to what ligand? Is it to A. Fibronectin, or B. glucan, or C. heparan sulfate, or D. mannose, or is it to E. phosphocholine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. phosphocholine. I will clarify why. C-reactive protein enhances phagocytosis by binding phosphocholine, present on foreign pathogens and damage host cells, and activates complement. Please advance to the next question. And the next question reads, HAW, a 24-year-old woman was admitted with 2 weeks of painful finger joints and 1 week of high fevers and a rash. HAW described the fevers as occurring every evening, and she would have normal temperatures in the morning. The rash only appeared during febrile episodes. On direct questioning, HAW recalled that her symptoms had been preceded by a sore throat and some swelling of the lymph nodes in her neck. On examination, HAW's temperature was 39.1 degrees Celsius, her heart rate was 96 beats per minute and her blood pressure was 105 systolic 62 diastolic. HAW had a salmon-pink macular rash over her trunk, upper arms and thighs. There was no swelling or tenderness of the small joints of the hands. Cardiovascular and respiratory examinations were unremarkable. HAW's spleen tip was just palpable. Investigations were done and results were as follows. Her white cell count was 25.8 times 10 power 9 cells per liter. The normal value is 4.0 to 11.0 times 10 power 9 cells per liter. Her neutrophil count was 24.2 times 10 power 9 cells per liter. The normal value is 1.5 to 7.0 times 10 power 9 cells per liter. Her platelet count is 468 times 10 power 9 per liter. The normal value is 150 to 400 times 10 power 9 cells per liter. ESR is 90 mm per hour. Her CRP is 12 mg per liter. The normal value is below 10 mg per liter. Albumin is 24 grams per liter. The normal value is 37 to 49 grams per liter. Ferritin is 3,245 micrograms per liter. The normal value is 15 to 300 micrograms per liter. So my question to you is, what is the most likely diagnosis? Is it A. adult Still's disease, or B. Epstein-Barr virus infection, or C. familial Mediterranean fever, or D. rheumatic fever, or is it E. systemic lupus erythematosus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. adult Still's disease. I will clarify why. There is no definitive laboratory test for adult Still's disease, but it is the most common rheumatologic cause of fever of unknown origin. The diagnosis is largely clinical, and includes criteria such as the characteristic evanescent salmon pink rash, fevers over 39 degrees Celsius and a neutrophilia. Markedly elevated ferritin levels are a key clue. Please progress to the next question. And the next question reads, VCT, a 42-year-old man presents with fever, myalgia and headache. On examination he is febrile, tachycardic and hypotensive. VCT has bilateral subconjunctival hemorrhages. There is a petechial rash over his shins. Investigations reveal that VCT has an acute kidney injury, thrombocytopenia and an elevated bilirubin. A working diagnosis of leptospirosis is made. So my question to you is, what activity is most likely to have exposed VCT to infection? Is it A. competing in a triathlon, or B. orienteering, or C. playing rugby, or D. sea bathing? Or is it E. visiting a petting farm? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. competing in a triathlon. I will explain why. Recreational exposure to water is regarded as a significant risk factor for leptospirosis. Although the rates are low in this risk group in the UK, there have been outbreaks of leptospirosis reported among triathlon competitors. The leptospires are transmitted in the urine of infected animals, classically rodents, but including many kinds of wild and domestic animals. The density of the local rodent population is more important than the overall water quality. Please progress to the next question. COK, a 63-year-old crab fisherman developed a painful lesion on his left ring finger. COK first noticed throbbing at the tip of his finger, following which a slowly enlarging lesion developed. There was some stiffness in COK's index finger, but he had not noticed any swelling. COK had not experienced any fevers or rigors. COK felt as if the pain he was experiencing is proportionately greater than the lesion seemed to warrant. On examination, COK's temperature was 36.8 degrees Celsius. There was a violet-colored lesion on COK's left index finger of 4 cm in diameter. This had a raised border with central clearing. There was no swelling associated with the lesion, nor was there any tracking lymphangitis. So my question to you is, what is the most likely causative organism? Is it A. Bacillus anthracis, or B. Erysipelophthirix ruseopathiae, or C. herpes simplex virus, or D. Mycobacterium marinum, or is it E. Sporothrix schenki? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Erysipelophthirix ruseopathiae. I will clarify why. Erysipelophthirix ruseopathiae is a gram-positive bacillus which is ubiquitous in nature. Humans usually develop a local infection through direct contact with an infected animal or animal product. At particular risk are butchers and fishermen handling crabs, but also farmers, abattoir workers and veterinarians. There is no documented human-to-human transmission. Please proceed to the next question. And the next question reads, MOA, a 49-year-old librarian attends the emergency department with a painful swollen right fist. MOA had sustained a bite injury from a stray cat 24 hours before. On examination, MOA's temperature is 38.1 degrees Celsius. There is an incisional wound with purulent cellulitis over the MCP joint of MOA's ring finger on the right hand. Movement in the joint is very painful and limited. There is tracking erythema spreading up towards MOA's elbow. Blood cultures are taken and MOA is taken to theater by the plastic surgeons for exploration and debridement of the wound. Results of the investigations were as follows. Blood cultures. On day 1, there were small gram-negative cocobacilli. On day 2, there were gray mucus colonies on blood agar at 37 degrees Celsius. There was no growth on McConkey agar. So my question to you is, what antibiotic would be active against this organism? Would it be A. cephalexin, or B. clindamycin, or C. erythromycin, or D. gentamicin, or would it be E. penicillin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. penicillin. I will explain why. The organism is most likely to be Pasteurella multocida, given the history of a penetrating cat bite, the aggressive nature of the infection manifest in the speed of onset, the associated bacteremia and the likely tenosynovitis. The microbiology findings are consistent with this epidemiological and clinical suspicion. Penicillin sensitivity is used within the laboratory to distinguish Pasteurella species from other gram-negative bacilli. Please proceed to the next question. And the next question reads, MPL, a 38-year-old man presented with a 3-day history of fevers, myalgia, a non-productive cough and chest pain. MPL had vomited 4 times in the last 24 hours, and had developed abdominal pain and a headache. Investigations were done. The results are as follows. Neutrophil count 14.5 times 10 power 9 per liter. The normal value is 1.5 to 7.0 times 10 power 9 per liter. X-ray of chest is shown in the photograph in the next slide. CT scan of chest is shown in the photograph in the next slide. Pause the video and carefully scrutinize the photo depicting an X-ray of the chest and a CT scan of the chest before advancing to the next slide. If a bioterrorism event is expected to have provoked his illness, what would the most likely causative organism be? Would it be A. Bacillus anthracis, or B. Burkholderia pseudomorle, or C. Coxiella burnetii, or D. Francisella tularensis, or would it be E. Yersinia pestis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Bacillus anthracis. I will justify why. The clinical course of inhalational anthrax begins with a prodrome that is indistinguishable from common viral respiratory tract infections. Abnormalities on chest radiography commonly include pleural effusions, consolidation and mediastinal adenopathy or widening. CT is more sensitive than chest radiography for mediastinal adenopathy. Please progress to the next question. And the next question reads, SLD, a 64-year-old woman is admitted for a left total hip replacement. SLD has hypertension, for which she takes amlodipine. She has no known allergies. SLD receives 1 dose of teicoplanin 10 minutes prior to skin incision. A urinary catheter is inserted. SLD's total operative time is 55 minutes. During the operation, SLD is warmed with a forced air blanket and fluid warmers are used. SLD is transfused 1 unit of packed red cells during the operation for perioperative blood losses. So my question to you is, what is most likely to predispose her to a surgical site infection? Is it A. ACE score, or B. blood transfusion, or C. operative time, or D. timing of antibiotic prophylaxis, or is it E. urinary catheterization? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Blood transfusion. I will clarify why. There is evidence that allogenic transfusion of red blood cell concentrates is immunosuppressive and increases the risk of nosocomial infection. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 220.